cervical cancer first. So what shook the world was the publication of the LAC trial in 2018, and what till evidence before that was with small number of studies with high bias, and people were doing minimal access surgery. But shockingly, this trial showed a significantly decreased 4.5-year survival at 85% in MIS versus 96% in the open technique, with a hazard ratio of 3.9. So that means patients who are undergoing MIS are almost four times more likely to recur. And in terms of overall survival, at 44.5 years, the survival was also less, 90.6 compared to 96% in the open technique, with the hazard ratio of 2.7. This is according to the updated survival analysis published in the JCO in August 2024. So there was a lot of data from respective countries, from the East, from Europe, from US, and what the evidence showed, the guidelines also incorporated, including the ESCO, the NCCN, the FIGO, and also the ESMO. So it replaced the standard of care. But what this trial did had some limitations as to it was not the primary statistical objective was not reached. It had low power when evaluating tumors under 2 centimeters. The tumor size determined by either MRI, the intraoperative, or on the final pathology specimen was varied and not concrete. And the differences in the patient and the tumor characteristics, they were so heterogeneous as to be contributing to a bias. And higher parametrial involvement was noted in MIS, which made the readers question the surgical proficiency of this trial. It was not designed to answer the questions as to why this inferior oncological outcome is seen. There were some insights like, was this approach, the lab, if we could have done a lab, because only 16% of the patients were robotic and the rest were laparoscopically. Was it the approach which could have given this inferior outcome? Was it the tumor dissemination at the time of colpotomy? Was it the effect of CO2 peritoneum? Or was it the tumor size? Or was it the lack of radicality? We'll just be touching upon these insights. Since we know that robotic is equipped with 3D visuals, instrument articulation, tremor filtration, motion scaling, and improved dexterity, then the radicality should not be compromised. And what we saw in evidence brought up by the Mayo Clinic by Yang et al., that the vaginal margins and the parametrium were comparable. So it could not have been the lack of radicality, but this is a different data. As I said, the trial was not powered enough to see these things. So the data was giving plausible explanation. If it is not the lack of radicality, could it be the tumor contamination or improper tumor handling at the time of MIS? To answer this question, we have two big trials, the ROC and the RAC. All my gynae-oncologist colleagues would be familiar with this trial. And this aim is to compare the robotic versus open surgery and evaluate the DFS. In the ROC trial, it is mandatory that the transcervical uterine manipulators are not used, and there is specific detailed surgical techniques for proper tumor containment. Photographic evidence of the specimen with the tumor containment is mandated to overcome the problems with the LAC trial. The counterpart, the similar trial is a Swedish trial, which is the RAC trial, and it is also going to be it's already started its recruitment and is going to be closed in May 27. It is also an RCT, 1:1 randomization, but the difference with the ROC trial is that the use of vaginal manipulators, vaginal manipulators is recommended and not mandatory. The tumor size was questionable because LAC was not powered to assess the outcomes in low-risk tumors. At that time, in 2018, the stage 1B was not subdivided to less than 2 or 2 centimeters. As we know, the FIGO 2009 staging was going on and the tumors were less than 4 or 4. So we do not have the adequate statistical analysis to say the contribution to the tumor size. Now we have data coming up with the SHAPE trial, and there is less radical surgery may be sufficient for low risk early stage cervical cancers. We have a lot of conflicting data. We have studies from Upwell and Odeto which say that the inferior outcomes, they noticed inferior outcomes even in the tumor size less than 2 centimeter. And then we have European study, the Dutch study, and the Korean study saying that we did notice the tumor size when it was less than 2 centimeters, the survival was equivalent to that of the open surgery. Sucker trial, it was a retrospective observational study to compare MIS and open, multicentric European trial. It avoided uterine manipulator, and as you can see in the picture, vaginal closure and protective closure of the colpotomy over the tumor was done. The recurrence risk was twice as high, and the risk of death was 2.45 times in the overall population, but these outcomes were not seen in lesions less than 2 centimeter size. And if you look at the subset of protective vaginal closure, then similar DFS in the MIS was observed. And if you did not have protective measures during the MIS, there was 2 times higher risk of recurrence and 2.85 times higher risk of death as compared to open surgery. After the tumor size, one of the speculations and the most important speculation where we are working upon and trying to improve is minimizing the tumor dissemination in the time of MIS for cervical cancer. Can we do a preoperative conization rather than a cervical biopsy? Can we do a vaginal closure method for everybody? Should we stop using uterine manipulator altogether? So conization, like logically also we know that if there is no residual tumor, then there is less chance of tumor spillage and automatically your results will be better. So sucker cone study was done, and you can see those 4 graphs, and the orange one is the inferior most outcome when you do an MIS without conization. And the red one is the standard of care, which is the open surgery and conization done. So that is the reference arm. And when you see the blue line, that means that when you do an MIS along with conization preoperatively, the outcome is comparable to that of open. So this is concrete evidence, but still it is not an RCT to be contributing to this data. Kohler et al. Gave excellent evidence and very well explained as to why this could be happening. When we we use the manipulator, the vagina is already stretched, and we do a colpotomy. That in the stretched vagina, the monopolar hook tends to create a gap, which tends to make the tumor dissemination more likely. And they suggested the vaginal assisted laparoscopic radical hysterectomy, as you can see in the diagram, where 6 Pockard's clamps are holding the Lugol positive iodine area. Then you do, with a continuous suture, you do a vaginal closure. Then you do the radicality of the surgery, marked with the green areas, and create the vesicovaginal and the POD space. So these are some methods to ensure that the tumor spillage is not done. And in their trial, they incorporated this for everyone. Now we have recent evidence regarding the radicality of surgery, and I would request Dr. Stefano to also shed light on it, because we know with the results of the lesser trial, the SHAPE trial, the GOG 278 trial, we know that non-radical surgery for early stage cervical cancer is safe with low perioperative outcomes. None of these explore the question of surgical approach on oncological. We know that if we are doing a simple hysterectomy, is it not prudent to do it minimal access way for early stage, low risk cervical cancers? And that is the basis of the LASH trial, which has been designed to look into this. It is a prospective single-arm trial, and it will begin its accrual shortly in patients meeting the shape criteria and undergoing MIS simple hysterectomy with also the combination of sentinel lymph node algorithm. And its primary endpoint is going to be DFS at 3 years. What another insight as to what carbon dioxide does is that it activates mitosis. It pushes the cells into the S phase, leading to more tumor growth. Also, with the effect of CO2, the mesothelial lining tends to be shaky and kind of helps the cells to migrate and disrupts the peritoneal lining. So, and also CO2, the acidic environment of the CO2 has been shown to harbor the immunosuppression activity of the patient. So there is immunosuppression already because of the CO2 pressure. And intracorporeal colpotomy, which we are doing, if we are doing an intracorporeal colpotomy, we can do the vaginal closure as I explained, and also the low pressure pneumoperitoneum, abdominal wall lifting, and vaginal colpotomy rather than the intracorporeal colpotomy might give better results. Currently, the guidelines, the updated 2023 ESP guidelines for cervical cancer suggest that minimal invasive approach can be considered only in the low risk tumors, less than 2 centimeters, and pre-margins after conization in only high volume centers with experienced surgeons performing radical hysterectomy and MIS, which meet the ESCO quality criteria for surgery, and if the patient agrees after comprehensive discussion about the current evidence, because one of the speculated reasons was that the surgical expertise was also questioned because the LAC trial had surgeons with low accrual rate. Some centers showed only 2 accrual per year. The learning curve of the robotic surgery was they just had to do 10 robotic cases and send their unedited videos of only 2 in number. So to decrease the likelihood of chances of poor outcome based on surgical expertise, these measures are taking place. I come to ovarian cancer, and as we know, it is a deadly disease with we diagnose it as higher stage, poor outcomes. We all know that optimal cytoreduction is the key, and nothing can beat the tumor biology. And when we have to do a comprehensive surgery, we do midline cuts, which take longer to heal, and sometimes the chemotherapy is also delayed. I'm sure all my Gynae-Onco colleagues would have had patients with surgical site infection and always worried about starting chemo early. We know that benefits of MIS, particularly in ovarian cancer, will decrease the hospital stay and resume the chemotherapy early. But the concerns are that we do not know the safety yet. There is lack of high quality evidence. There is potential rupture of the ovarian capsule. And that is why young surgeons are not as keen to start with MIS, especially because of the data which is available, and also in suspicious cases, because tumor rupture may lead to upstaging and mandate chemotherapy, which might not have been done. The risk of port site metastasis has been reported up to 16%, but recent data suggests 2 to 3% is the risk of port site metastasis. There is inability to manually palpate the lymph node as we do. We know we usually do the current practices in interval CRS. We are not doing non-palpable or non-enlarged nodes. But when we are doing an MIS, we cannot even see for the texture of the lymph nodes. So the laparoscopic skills to achieve the cytoreductive surgery are also going to play a important part. What does the evidence say currently? For select patients, MIS can be employed if the surgeon is experienced in early stage cancers. Laparoscopy may also be used to evaluate optimal CRS in patients diagnosed newly with advanced cases, and minimal access techniques can be used for select patients for interval CRS. I'll be talking about the evidence very soon. Even in the recurrent cases, in addition to the preoperative imaging, we are already, as surgeons, questioning the right candidate for the secondary cytoreduction. And laparoscopy may be used to determine if complete resection can be achieved. Secondary CRS can be performed with either open or MIS. Consider using validated scoring systems to assess the suitability of secondary CRS. So I will just be touching upon the role of MIS depending upon the situation. If you have an early ovarian cancer, the most important is the concern of intraoperative rupture. And it has been shown by Park et al. That you can choose with your surgical expertise. This is where one size does not fit all. Depending on your surgical curve, you can choose which is the tumor diameter that you are comfortable with. What is the tumor diameter that you feel that in suspicious or early stage you can retrieve the specimen in an endo bag without rupturing the capsule. Recent data suggests that the port site metastasis is about 1.9 to 3%. And this study was based on 2,251 laparoscopic procedures. This also makes chemotherapy be started early, and like any MIS, lower complication rates are also observed in early stage ovarian cancers. I will not go into detail of this table, but we have only short small number of studies with small number of cases with smaller median follow-up. So that is why it cannot be the standard practice right now. And we need more evidence, more high quality data. One of the meta-analysis and systematic reviews published recently in BMJ showed that for early stage ovarian cancer, laparoscopy versus laparotomy did not show a difference in the OS. It did not increase the upstaging rate, and there was no difference in PFS also. In fact, it was associated with lower rate of recurrence. And this meta-analysis was done based on 5 studies, and one of the studies is from IRCC's Gemelli. In advanced stage cancer, this is where I would request Dr. Stefano to also put in a word. We know, we are aware of the Fagotti scoring system, one of the validated systems for laparoscopic assessment of surgical staging and the likelihood of cytoreduction, complete cytoreduction. And based on this criteria, when we see there are total 7 parameters, each score is given to 0 or 2, depending on the conditions that we see. This is how the ports are placed. And after the scoring system, we get a PIV, or the predictive index value. Anything between more than 8 or equal to 8 has a likelihood of suboptimal surgery with specificity and positive predictive value of 100% and negative predictive value of 70%. This was published, this is Fagotti 2006 rather than 2016. I'm sorry for this. And there were subsequent trials also. Not only does laparoscopy assess the tumor load and optimal CRS, but it also, if you cannot do a CRS, you can take an amenable biopsy from the required sites. Because sometimes we are struggling with the NACT and we cannot have a biopsy from a good site and the tumor histology. Like we know, low-grade serous cancers, mucinous cancers of the expansile type do not respond well to chemo. So it is more important in such cases to do a surgery first. Apart from that, laparoscopy is also predictor of the post-operative outcomes. So if you have a performance score of more than 2, ascites more than 500 ml, CA-125 more than 1000, and a tumor load which is high, then the likelihood of complications is also severe. And if you have a combined score of 8, it can also have you are half as likely, half of the times you will have CTC grade 3 or 4 complications. So the challenge is, it is easier. We know that the feasibility is there. There is some research required, but when you talk about it practically, there are some challenges that a surgeon faces. One challenge is that in terms of peritoneal carcinomatosis, the bowel comes and stick right at the peritoneum. So when you are placing your trocar, you might just enter the bowel. That is why some centers always use the open technique of laparoscopy rather than doing a closed technique. There can be intraoperative adhesions which are totally obscuring the view. There are challenges with the patient habitus that she cannot go to a Trendelenburg position, and you might need to change the position depending on how she is behaving from the anesthesia point of view. If she has previous surgeries, then that is all the more makes her job more challenging. And obviously, we have to look into port site metastasis. How do we overcome these challenges? Is, as I said, open technique. When you are assessing for cytoreductive, optimal cytoreduction, you do drain the complete ascites. If there are more adhesions, consider placing additional trocars, and that comes with surgical expertise. There have to be careful adhesiolysis, and the whole unit, the whole team has to be adhered to a certain protocol. When you want to publish it, when you want to objectify your data, the protocol adherence is a must, because we might be able to give robust evidence for future trials. Once you are done, remove all the residual gas and irrigate the port site with saline, and sometimes povidone iodine solutions also some authors are doing. So make sure that the gas is gone. Make sure that you're irrigating your ports. So if these things can be abided by, laparoscopy for advanced cases also may be feasible. So Lance trial, a recently published trial, looked into the feasibility of conducting an RCT to compare the efficacy of MIS versus laparotomy in advanced EOCs. So it was a non-inferiority open label international trial incorporating stage 3 or 4 cancer cases and the outcome measures. First, we begin with, can we do it? Is it feasible to do an RCT? Do we have the right kind of patients? So the patient accrual rate of at least 5.6 patients per month at the end of the trial. So this lasted for a year. MIS conversion to laparotomy should be less than 25, should be less than 25, and the difference in the complete gross residual resection less than 20% difference. So if you are attaining a CGR in open, less than 20% should be the difference in the MIS. So this trial showed that it is feasible. They had, instead of 5.6, they had 5.9 patients. They had less than 25% chances of conversion to laparotomies. CGR was obtained in 88% in the MIS and 83%, giving an absolute difference of only 4.5% rather than a 20%. And it was also associated with shorter hospital stay, lower estimated blood loss. So a full-scale RCT comparing the oncological efficacy is feasible. There is more. So it does have a role in recurrent cases also, but the data is limited. I will skip this slide because we have small evidence, but not robust enough to determine so. We do see that the post-operative outcome is better in terms of surgical efficacy, but we are still questioning the oncological efficacy. And I think that is it from my side. Thank you all. If chairpersons have any questions.
Just wish to say, if I talk about the ovarian cancer, in the early stage ovarian cancer, what is the problem? There is an ovarian mass. You are manipulating that ovarian mass, and you have to manipulate that ovarian mass to apply the infundibular ligament, to clamp the IP ligament, right? And the moment you manipulate that ovarian mass, you are disseminating the disease. There is no doubt about it. And the cause is CO2. In my practice for last 22 years, I have seen a lot of four-side metastasis, and believe me, they don't respond to the chemotherapy at all. Because the abdominal wall metastasis, the blood supply is poor over there. So they don't respond to the chemotherapy. I have seen. So if you talk about ovarian cancer, the early stage, I think if it's very small, you can. But if I compare my result of laparoscopy with the nephrotomy, you can take a lot of precautions and give a good survival to the patient. That means if you talk about the bone disease, you can take a lot of precautions so the bone complication decrease. However, the medical oncologist will give chemo only after 21 days. They will not give, even if you are doing the laparoscopy or the laparotomy, but before 21 days, they will never give. Whatever the method you are doing. If I talk about the advanced stage ovarian cancer, in all the advanced stage ovarian cancer, I always put a laparoscopy first. I always do put a laparoscope first, see the disease status, that whether I can do a good surgery and if I cannot do a good surgery, I just take the biopsy, send the patient for next. Right. If I talk about the secondary cytoreduction, if it's isolated metastasis, it is always better to go ahead with the laparoscopy. If you can go ahead with the laparoscopy, if it is an isolated metastasis, go ahead. Supposing there is sigmoid colon metastasis, go ahead with the sigmoid colon section. But if it is disseminated disease, I don't think that there is any point of going ahead with the MIS. Thirdly, if you talk about the interval cytoreduction surgery, at the end of the surgery, you just see, we keep on seeing the small intestine and there is a small disease in the serosal surface, in the mesenteric border. How you can explore the whole of the bowel with your robotic arm, I don't understand. You just see, you keep on doing. Do you do?
So first, for the first point, I totally agree for the early ovarian cancer. I think in 2023, we have published a study that is called Loch Ness studies. I don't know if you have read the study, and there is a score, a Loch Ness score, that we use to decide when we have to open and when we can do laparoscopically remove an ovarian suspicious ovarian mass. And the most important factor to decide is the size. So usually it's not the same because it's a score. So it's not the only factor, the size. But usually when you have more than 8 centimeters of the size of the mass and the CI 125 that is not negative, in the majority part of the situation, you have to open because we have seen that the risk of disseminating the disease is very high. It's too much high to be mini-invasive surgery. So I agree with this. For talking about the minimal invasive surgery for recurrent disease, yes, I think that it depends from the origin of the recurrent disease. Because if you have carcinosis as recurrent, it's very difficult. That is the only localization of the recurrence. And if you have carcinosis, you have to explore. No. If you have lymphanoma recurrence, so for sure it's important to get relative assessment. If you have relative assessment, and only for metastatic disease, you can try to use the minimal invasive approach. But also, but the probability is that I think the measurement of the red blood cells is most important. For the lymph node red blood, I think yes, one of the solutions. For carcinosis, all this oligostatic, in my opinion, I think I will explore domains of this good idea.
So regarding this lactile initially, what I believe as a surgeon are very poor in designing trial. I believe the 47 is the example, lactile is the example. If you see the literature, minimum 30 to 70 oncosurgery laparoscopy is required to overcome the learning curve. Here they recruited I think 2 per year. That is, suppose I am an open surgeon, I hit the high pay, and somebody I just include my name in the trial of lab trial. So this is not justified for the patient. So this is the thing. Anyway, like in ovarian cancer, cervical cancer, what I believe, you have to be master of that. So if you overcome your learning curve, then you can only justify. Like suppose ovarian cancer, they are telling in early cancer selected patient, you can go for this thing, don't know about it. Because if you have the master of it, even the internal suppose like I am areas because you know the way it is disseminated, you put the density, then you go for this thing. So assessment of the disease is very difficult to do, particularly in the subdural area, retrohepatic area, retromedial nodes, so pelvic area, deep area. So it's a slightly difficult to particularly localize the disease, interval setting. But recurrence setting, yes, because the commonest recurrence in ovarian cancer is the peritoneum. You can put the laparoscopic, so the only the peritoneum it is, you can put the resected disease, that is the thing. And other is suppose in visceral mates or somewhere localized disease. I think you can easily do the laparoscopy. There is no doubt, and particularly the robotic. So that selection is the point. We all know that we have to respect the biology, and selection is the point that is also very important. And if you are the expert, you can. But that before that you have to be expert. That is my input.
But sir, basically, as long as the cervical cancers are concerned. So, what do you think? What is the number of the operable cervical cancers people are encountering? Whether it will take them some like 4 or 5 years to reach that level of the threat level.
More than that.
Yes. So that is the basic issue. So most of the people are like, LSCC is the only trial which is a phase 3 trial having some data regarding the oncological outcomes of the cervical cancers. So there was a time actually when Paresa was like pushing this thing at some conference forum, and I was like very much against this trial that I was thinking, yes, why there. But over the period of the time, with my personal experience also, I have seen that yes, the endometrium is a different disease and the stem cell carcinoma cervix are different. So doing the endometrial cases with laparoscopy or robotic outcomes are different. But yes, if you are dealing the same thing with the cervix, even with the early cervical cancer, that's 2 centimeter reasons also. Then the chances and if you see the LSCT outcomes also, the most of the not most but almost like 50% differences are the upper abdomen. So there is a change of the biology basically which is predicting how is the outcome. It's not just only the for the endometrium it's doing better. Adenocarcinoma is good. But if you're considering this, both things are important. The ones the endometrium is more and more over people laparoscopy. But yes, also the nature will also good. So stem cell carcinoma is behaving differently. I think the chance of the spread with the pneumonia and everything is more with the stem cell carcinoma. So I personally, my personal observation, so this is really challenging to get a experience of 25 and 36 cases of laparoscopy cases which go into that level where you can participate. There are very few surgeons who can actually come to that point.
Thank you.
To ask one question, like a number of minimal cases in ovarian cancer. One case I was operating, like ma'am said, we also like suspected one advanced ovarian cancer. We first used to put a hold, and we used to see because of label, we used to convert it into open. But I was doing it was it seemed like advanced stage, but when the scope it seems operable. So then a GA surgeon came to and he said, you will give a big incision. Why not you do a total lumpectomy and see upper abdomen is okay by laparoscopic approach, and you can incision will be less, then you proceed the pelvic surgery with a small incision, the biggest. So how can we like this? Is there any role of laparoscopy like in advanced stage? Upper abdomen is okay, like omentinized. Can we combine this to decrease the incision and will it be beneficial to the patient?
giving this much of
This
incision
one
or
this
that
is-
Yes. So it's either open surgery or a minimally invasive.
what care you are taking to prevent the wound disease? What you have to do? You have to scrub, you take all the precautions. I have seen a less number of wound complications. I'm telling you, I have seen a very less number of the wound complications than tried anywhere. You have to take all the precautions. What is the idea of giving this incision or that much of incision? Give a good incision if you're going to go ahead with a good surgery.
If that was my point, but they again, I
When
will
you have to do the retroperitoneal lymph nodes. And you have to approach till the renal vein, and for the renal vein, you have to go ahead with the supraumbilical. How you can go ahead with it? With a minimum incision to the renal vein, I don't think you can go till the renal vein to take out the para-aortic lymph node. For to taking out the para-aortic lymph node, you have to go ahead with the supraumbilical, and you have to apply the concentrator.
So if you see the sugar picker also, he routinely just remove the GP sternum also. You know, you cannot tackle the upper abdomen without taking the extension up to the GP sternum. So you cannot do that.
Be ready.
For the ovarian cancer particularly.
Yeah.
Thank you, ma'am, for the enlightening session. I think everybody in the room gained valuable insights. Now, let's move ahead with the session 1, topic 2, that is sentinel lymph node in gynecological cancers.
Thank you to all my dear listeners, and we'll be having the felicitation after the 2 talks and before the panel discussion. So please go ahead.
Now, let's move ahead with session 1, topic 2, that is sentinel lymph node in gynecological cancers, current status and the way forward. The chairpersons for the topic 2 are first, Dr. Rahul D. Modi. He is the lead consultant, Division of Gynecological Oncology, SGRH, New Delhi. His fields of interest are CRS, HIPEC, sentinel node mapping, molecular and precision medicine, AI in Gynae-Oncology. His achievements include Shingo Fuji IGCS Young Doctor Awardee, Shashikant Fellowship Award, Young Doctor, Berlin. Next, we have Dr. Professor. Hi.
There needs no introduction.
Next up, we have Dr. Dweep Jindal, MBBS, MS, OBG, Fellowship Gynae-Oncology, Senior Consultant, Max Super Specialty Hospital, Noida. His fields of expertise are gynecological cancer surgeries, minimal access surgery, robotic surgery, fertility sparing surgeries, cervical cancer treatment, and ovarian cancer treatment. He has authored multiple papers in various journals and books, and he has won the second prize for the presentation at AGOI CON 2018. Next up, we have Dr. Shruti. She is the consultant gynecological oncology and gynae-endoscopy surgery, laparoscopic and robotic, Mazumdar Shaw Medical Center, Narayana Health City, Bangalore, India.
Welcome, Dr. Shruti. Thank you for flying from so far.
Now it's my pleasure to welcome Dr. Stefano. It's a long list in my hand like this. So, but to me, like whatever I got introduction with him, he's looking like a Hollywood hero. And I want to, he's a very good human being, very happy, charming, and it's that should be the quality of his study. Without much introduction, I request Stefano to talk on the topic.
We have one more chairperson, and she has come all the way from Jaipur, Dr. Apurva Dutt. She's a close friend of mine, and she's leading in Jaipur in a cancer center, which is one of the oldest, Bhagwan Mahavir Bhagwan Cancer. Welcome.
Thank you. First of all, I want to thank all the organization. I want to thank the media. I want to thank Professor Rai I want to thank because it is an honor. I'm glad to stay here today, to come here from Italy and to have the possibility to learn, to improve my knowledge from you. So thank you so much. So today I want to talk about the sentinel lymph node in gynecological cancer. When we talk about the sentinel lymph nodes in gynecological cancer, we know that to date, in all Congress and in any part of the world, there is always a session that talk about the lymph node role in the gynecological tumors. Every day, the publication in this field are increasing. So there is a risk. It's a good thing, obviously, but there is a risk. There's a risk of the too much information. So I think that these sessions, this kind of session where we summarize are really useful to understand where we arrived and where we are going. So I try to do this for every work. Okay. Okay. I try to do this for each tumor of gynecological cancer. So we know in this part I'll be very quickly because all of us know the gain of to use the sentinel lymph nodes because lymphadenectomy is related with an increase of operative time, measured vessel injuries, and nerve lesions. The risk of this kind of problem are approximately 4% per surgery. And there is a risk of also comorbidity early and post-operative complications like kelocytis, lymphedema, and lymphocysts that are very rare in when we use only sentinel lymph nodes. Okay, we can start with endometrial cancer. Also for this part, I want to be an interested presentation. So for this kind of studies that we know very well, like FIRE trial, that is very common to be one of the first trials that are famous to be the first proof that the sentinel lymph node can be used safely in the story and in the endometrial cancer. So these studies are very known, so I go quickly, but it is very important to say that we can use the sentinel lymph node for a specific type of tumor when we are sure that there are proof for feasibility, accuracy, and oncological safety. And these are all endpoint that was reached in endometrial cancer. And this is the reason why in the last guidelines of the ESGO-SOS guidelines, we see a specific place for the role of sentinel lymph node. We know, in fact, that in the last 24 years, the sentinel lymph node became a safety tool when we talk about the low risk endometrial cancer. For high risk endometrial cancer, for the last guidelines, there is not so clearly because we know that the guideline says that it is feasible. We can use the sentinel lymph node, but it's not clear. There are not prospective trials that prove that the oncological safety is the same for the sentinel lymph node and the systematic pelvic lymphadenectomy. But after these guidelines, there are some other published studies like this one of Capozzi that talk especially about the population of high risk endometrial cancer. Especially, he included in this study 237 patients that are high risk endometrial cancer. And he demonstrated that this is, yes, it's true, is another multi-center retrospective trial study, but is conducted very well. And he showed how the disease-free survival and the overall survival were not different between the two populations of pelvic sentinel lymph nodes and full systematic lymphadenectomy. Another important point of this study is shown that neither overall survival nor disease-free survival were different among sentinel lymph node alone and lymphadenectomy group in patients with nodal metastasis. So we know that also for patients that have nodal metastasis, there is no curative role of the lymphadenectomy. This is important because to be safe to use the sentinel lymph node, the lymphadenectomy can't have the role of a curative role. So this is another confirm that sentinel lymph node alone is safe, also for high-risk population. There is in the 2021 studies where a group of expert gynecologists with Delphi methodologies do a consensus where we can find exactly the specific step to follow to do this technique very well and safe. This is the consensus. Here we can see some very important information. For example, ECG is mandatory, the use of the tracer ECG. We can use other tracer, but ECG have to be used. The injection have to make in the ectocervix superficially is mandatory, and is prohibited use in injection in other places like in the past, for example, with hysteroscopy or injection transperitoneal of the uterus. But I want to say that often in Italy we say that rules are made to be broken. Okay, I'm joking, but there is some cases when the standard is not possible. For example, last year we have published this video where we have a patient that have a very severe vaginal stenosis. This is the vaginal stenosis. Cervix is not accessible. It's impossible to inject the cervix. So we have to decide what we have to do. We have to do the full pelvic lymphadenectomy because the injection is not possible, or we have to try something else. So there are studies that says, anatomical studies that say that the drainage of the whole uterus conduct an output in the region of the uterine artery. The both parts, the fundus of the uterus and the cervix of the uterus have channels that conduct into the region of the uterine artery, and there is there the output of the channel outside the uterus. So for this reason, maybe an injection on the fundus, an injection of the cervix can reach the same output from the uterus, so can reach the same sentinel lymph node. And this is why in this situation, the injection of the fundus of the uterus permit to find an sentinel lymph node bilaterally. It's not the standard, but sometimes can is used. If we want to talk about some topic of the future in the treatment of endometrial cancer, the role of the sentinel lymph node in endometrial cancer in the future, we can talk about maybe the V-nodes approach. For example, in the last ESGO, we have performed this live surgery approaching with V-nodes and low-risk endometrial cancer, because we know that the V-nodes is for benign surgery to date, but is starting a new era where we think that it's possible for limited cases to use this kind of approach, this kind of access. For example, in low-risk endometrial cancer. We know that one of the limitations of V-nodes is not possible in V-nodes to explore the pelvic peritoneum. So we have to be sure that this technique is safe for the patient. We have done this case with our French friends, Dr. Thomas Gaillard and Dr. Enora Lass, and what we can see. Okay. Okay. At first, the access for the lymph node, the sentinel lymph node technique is a lateral access, is a retroperitoneal access, not intraperitoneal. So what we can see is that is totally upside down in the opposite from the laparoscopic view, because we are down. So what we see is a situation completely different from what we see laparoscopically. For example, now Thomas put the device of the V nodes. The gel point is a single port device, and we are going into with camera. The access is laterally from the cervix, directly retroperitoneal, not intraperitoneal. And what we can see is at first the obturator nerve, that is the last anatomical structure that we see in laparoscopy. We see after the obturator nerves, the iliac vessels, that is the first anatomical structure that we see, and finally, medially, the peritoneum in the medial, and the lymph node, and the ureter in the medial part. Here the ureter nerve, here the iliac vessels, and here the ureter. So in this case, when we have to find the sentinel lymph node, usually you find the sentinel lymph node at first in the obturator fossa, because it's the first station. So laparoscopically, you find the sentinel node in the deepest part. In this case, you find the sentinel lymph node in the most near part from us. But now we activate the near impacted vision. We can see that the obturator sentinel lymph node is this one, near the obturator. Okay, now we can talk about the role of sentinel lymph node in cervical cancer. Maybe as Divya talked before, is one of the most hot topic in gynecology oncology, because all we know the Sentinel trial. The Sentinel trial talk about the role of sentinel lymph node for tumor lesser than 20 millimeters. All we know that for this kind of tumors, we can say that sentinel lymph node is safe. But what is the role of sentinel lymph node in the guidelines to date? For sure, is recommended to do a frozen section of the sentinel lymph node, because the sentinel lymph node can say if you have to continue with surgery or if you have to stop surgery. Because if you have positive lymph node, sentinel lymph node, we have to stop surgery, and the full pelvic lymphadenectomy and the radical hysterectomy is contraindicated. Another role of the sentinel lymph node for cervical cancer is for early stage, very early stage. We know that for one stage 1 and LFSI positive evidence, sentinel lymph node can be done alone without full pelvic lymphadenectomy. Also for 1A2, sentinel lymph node biopsy can be considered for LBUS-SI negative, and should be performed for LBUS-SI positive. For 1B1 and 1B2, the concept is different, because sentinel lymph node biopsy before pelvic lymphadenectomy should be performed, but full pelvic lymphadenectomy is recommended. But what we know is that maybe one of the group, the most important group that published studies about the role of sentinel lymph node in cervical cancer is the Centicle group. They published, is the French group that published the first two Centicle studies, the Centicle 1 and the Centicle 2. First Centicle is for the accuracy of the sentinel lymph node in the cervical cancer. The Sentinel-2 trial is to study the difference in comorbidity between the sentinel lymph node and full pelvic lymphadenectomy. But after these two studies, this group, the Sentinel group, published these studies in 2022, where they take all node-negative population from the first two studies, and they see that the disease-free survival and disease-specific survival were similar between sentinel lymph node biopsy and pelvic lymphadenectomy. And the most important things about these studies is that the population of the Sentinel-1 and Sentinel-2, the majority part of the population is consists of cases of 1B1. And there are other parts also for 1B2. So this is a studies that maybe say that also for 1B1 is sure to only the sentinel lymph node. But for the moment, the guideline don't say that, and also for Sentinel group is not reached this information. This is why is ongoing the Sentinel-3, that is an international validation study of sentinel node biopsy in this kind on this stage of early cervical cancer. There is another trial, the LASH trial, as Livia said, that is a trial with principal investigator Niccolò Bizzarri. The name of LASH trial is the mixed of LAC trial and SHAPE trial. In fact, if you see, you can see that LASH is the first two letters of LAC and the first two letters of SHAPE. This is why, because this is a trial that takes one part of the LAC trial and one part of the SHAPE trial. We know that LAC trial is focused on the role of minimal invasive surgery versus open surgery. And the SHAPE trial is focused on the role of radicality, the total simple hysterectomy versus radical hysterectomy. It's true what Divya said about the LAC trial, about the update of the LAC trial that said that the power of the tumor less than 2 centimeters is not so high. But we have to maybe open eyes and see that in this update is confirmed that also for tumor less than 2 centimeters, minimal invasive surgery is maybe a problem. So this is the aim of the LASH trial. We want to study the role of a simple hysterectomy conducted for the LASH trial, conducted in the SHAPE trial, but only minimal invasive to see the minimal invasive role of the simple hysterectomy for cases, including using the same criterion used for the SHAPE trial. Another thing that, another aim, another endpoint of this trial, this new trial, the LASH trial, is to study the role of the sentinel lymph node alone without systematic pelvic lymphadenectomy for this population, for the population that reached from 1A2 to 1B1. So together with the Sentinel-3 trial, maybe it could be another studies that could demonstrate that sentinel lymph node alone can be safe also for 1B1 cervical cancer population. As I said, the principal investigator is Niccolò Bizzarri, co-principal investigator, Professor Denis Kirle. Now, I want to be very quickly for vulvar cancer because there are no very innovative argument about the vulvar cancer, and I don't want to do a scholastic presentation. What we can say about vulvar cancer is that we know that for many years, vulvar cancer is the first tumor in Gynae-Oncology when we use the sentinel lymph nodes, and we know that the standard of care is the use of technetium since the first year that we use the sentinel lymph nodes. But we have said that in the last year, there are always increasing the number of studies that prove that the role of ECG is the same of the technetium for vulvar cancer. for example, these studies published in 2024, that the ECG show a comparable performance parameters to the gold standard of radioisotope localization. Green ECG can be used with a standard open approach, but also with minimal invasive approach, endoscopic, laparoscopically approach for the lymphadenectomy. In this graphic, we can see how, in fact, the role of the ECG is increasing, and is the same now of the use of the technetium alone, and it's not yet the same of the use of technetium with other tracer, but the way is. For the ovarian cancer, the concept is totally different, because we are not so far. We are not at the level of the other pathology. We are just in the first steps to try to understand if this technique is feasible also for ovarian cancer. The first study published about the sentinel lymph node in ovarian cancer is published in 2014 by Klepp. He included 21 patients, few patients, and only 5 patients was malignant. He used blue dye and a radioactive tracer, but he showed an important percentage of injection feasible and the detection of sentinel lymph node. At least one sentinel lymph node detected in 100 of the cases included. But looking at this study, we have to talk about one problem of the use using the sentinel lymph node for the ovarian cancer. We have, differently from endometrial cancer and cervical cancer, 2 different pathway of drainage, because we have the infundibulopelvic ligament and the uterovarian ligament. So theoretically, we have to find 2 sentinel lymph node, one in the lomboaortic areas and one in the pelvic areas. Klepp don't studies this problem. But the real first trial conducted on the use of the sentinel lymph nodes in ovarian cancer is the CENTOF trial of Victor Lago. Victor Lago also in this case enrolled a few patients, because it's very difficult to enroll this kind of patient, early stage ovarian cancer. He enrolled 20 patients, and he showed how using ECG and technetium the detection rate is very high. There is a 93% of detection of pelvic lymph nodes and 100% of the detection rate of detection of the lomboaortic lymph nodes. The last year we have conducted this systematic review on the studies published on the role of sentinel lymph node in ovarian cancer in the last 5 years. As we can see, the studies in the last 5 years are very few. Is a topic not so popular, maybe because enroll patient early stage with ovarian cancer is very difficult. But he's published another important meta-analysis by Nuria Gusti, maybe the most important studies in the concept of sentinel lymph node, that confirm that also if we have few data, the global detection rate seems very high. The negative predictive value, it seems to be 100%. And so it seems that it's very useful also for ovarian cancer. This is another study of Nuria Gusti, the same author of the meta-analysis in the group of Barcelona, the MELISA studies, that confirm this data with other 30 patients. And he confirmed that using technetium ECG, the detection rate is very high, 19%. But after we have arrived, the Gemelli have arrived with the SELI trial. This maybe, not maybe, is the most big trial about this concept, because we have enrolled in 5 year, 176 patients, and is a multi-center trial, not monocentric trial like the first 2 that I show. And for our trial, we see completely different data, because we see that the detection rate is very low. We see a detection rate with 15, 18%, 0.6 of the detection rate, and a 15% of nodal positive. And the sensitivity of this 50% of nodal positive is 73%. So there is also the detection rate seems to be low, seems to be not so good, and the sensitivity also is not so good. So we seems that it's difficult to detect the sentinel lymph node, and maybe sometimes, often, there are skip metastases also. There are two big problems. And we wondered why our data are different from data of the Spanish school that show a promising technique for early ovarian cancer. We tried to find the answer to this problem, and we have reached some answer. We think that the first and the most important problem was the trace, because we use only ECG. I showed before for other tumors that ECG is very good, but maybe it seems that for ovarian cancer, ECG is not enough. Radio tracer, maybe if we want to continue to study the role of sentinel lymph node in ovarian cancer, is necessary. Another important problem is the volume of the tracer, because we used 2 milliliters of tracer. Nuria and Victor used only 0.5 milliliters of tracer. This is because maybe when we inject intraperitoneal the infundibulopelvic ligament with 2 milliliters of tracer, is very easy to expand the tracer, and so it's very common that you see all green, and it's very difficult to identify the single sentinel lymph node. So less volume of the tracer, maybe is the case. The use of ECG with radio tracer is the case. Another important data is about the double injection, because as we said before, they injected bilat in the two sites, in the uterovarian ligament and the infundibulopelvic ligament. Always we injected only in both ligaments, only in the 13% of cases. So injected in both ligaments, and the other answer that we found maybe were the key to improve our information and our effort to this technique. But there is one thing that is very interesting about the CELLI trial. Is we have found that the 63% of the sentinel lymph nodes positive are low volume metastases. We know that obviously the sentinel lymph node in ovarian cancer, so the ultra staging in ovarian cancer is very uncommon. So this is the first study maybe that demonstrate that the low volume metastasis maybe have a role also in ovarian cancer. And we started a new study about this called microovary, to study the role of the low volume metastasis also in ovarian cancer. We will see what is the role of low volume metastasis also in ovarian cancer. This is a study conducted by Uccella that maybe can be one of the solutions to resolve one of the biggest problem of the sentinel lymph node in ovarian cancer. One of the biggest problems is the difficulty of the technique, because the technique is not easy like in the medial cervical cancer, where injected the cervix is easy. For the ovarian cancer, injected the infundibulopelvic ligament is more difficult. Injected the uterovarian ligament is more difficult. Maybe using the same theory that I said before when we talk about injection of the fundus of uterus, the same could be the opposite. So if we injected the cervix, maybe the pathway of the drainage is the same of injection of the uterovarian ligament. And these studies prove theory because in these studies, cervical injection was performed, injecting ECG, and the bilateral uterovarian ligament injection was performed by injected another tracer, the methylene blue. What Uccella showed is that the indocyanine green and methylene blue identified the same lymph node in the 100% of cases. So to conclude, I talk about the effort that we have to do to improve this technique. All is resumed in this meta-analysis of Nuria Gusti that I think is one of the best study of this argument. And this is the last video of the presentation where we can have an idea to how is the procedure to identify the sentinel lymph node in ovarian cancer. In this case, is another video article of Nuria Gusti where she used the ECG and the radio tracer, and in this first part she injected the radio tracer before to remove the ovarian mass. After, she removed the ovarian mass, and if the frozen section confirms malignant tumor, she injected also the green, the indocyanine green, in the infundibulopelvic ligament and in the uterovarian ligaments. This is the first part, adnexectomy. And after the adnexectomy and the frozen section, the injection of indocyanine green in the infundibulopelvic ligaments. And after, we can see how she used very low volume of tracer. And I'm sorry for this problem with video, but it's evident here the sentinel lymph node in the paraoptic canal. And this, I think, is one of the best video article about sentinel lymph node in ovarian cancer. Okay. And sorry, but I want to dedicate this presentation to my mentor, our mentor, Professor Giovanni Scamia, that he passed away just 1 month ago. And I want to say, I want to show this citation of Scambia that is very beautiful in my opinion. Is one of the last citation of Professor Scambia of the last day. So thank you.
That was a very a great talk actually, and covering all the aspects of sentinel lymph nodes across all the gynecological cancers. Of course, like being our practice at Gangaram Hospital, only do at present only for endometrial cancers and not for cervical and ovarian, because they are still a part of standardization and it's not a part of guidelines as of now. For endometrial cancers, I wanted to know about 2 things. Of what is the protocol actually regarding whether you do sentinel lymph node for high-risk cases also for aggressive histology, especially the FIFO 2023, for example, the high-grade serous carcinomas.
Yeah.
And second, all the trials of sentinel lymph node are for uterus-confined disease. Like if we also do, of course, we don't have a level 1 evidence that it is actually oncologically safe.
Yeah.
The trials are going on, but everybody has stopped up doing it because there are trials which are going, I think, ALIS trial is going for high-risk cases and everything. So at Jenny, what is the protocol that will you do it for high-risk cases also? Only sentinel lymph node and no completion. And second, what is the protocol for selecting a patient? For example, what imaging do you do to confirm that it is a uterus-confined disease? A PET-CT or an MRI or a DT. So I just wanted to know about this.
Yeah. So, do you know very well our institution because you stayed in 2019 in Gemelli, and you know that there is an ultrasound center very dedicated to Gynae-Oncology part. So, to answer to the second question, sorry, I started with the second question. We know that the standard is is the MRI to study the pelvic, the local regional situation of the endometrial cancer. But usually we can attend to the ultrasound without problem because I think that there is a high quality of ultrasound. The ultrasound is enough. But if you are not sure about the ultrasound, the MRI is mandatory. Okay. And for the first question is, yes, we usually in this, to date, we use only the sentinel lymph node also for high risk cases, yes. But when there are some doubt about the localization of bulky lymph nodes or some suspicious lymph node enlarged, we perform the sentinel lymph node and remove the exploitation of the other suspicious lymph nodes. We don't use full systematic lymphadenectomy in the standard of our care.
So just want to understand that you all do central lymph node for all high grade, no enlarged lymph node on the imaging. You all do central lymph node for all high grade cases or just selected depending upon the high risk, the patient's performance status or how do you all do it?
But if you talk about the molecular classification, okay, yes, but we have to know that it's not accessible, the molecular classification. Usually when you have a case that come with a biopsy, maybe outside from the Gemelli, with the diagnosis of grade 3 endometrioid carcinoma or a serous carcinoma, you don't have information about and in this case, usually we also, if there are no localization in the lymph node stations, we use only sentinel lymph nodes.
So, so in your standard practice, you use central lymph nodes for all indications, provided there are no evidence when large lymph nodes.
Yeah. Because as we said with the Capozzi studies, but it's not the only study. There are 3 or 4 studies that say the same things. Also for high risk, if we perform the systematic pelvic lymphadenectomy, the oncological outcome doesn't change.
I would like to congratulate Stefano for such a comprehensive talk and also Dr. Divya for having arranged this. And over here I'll take an opportunity to let you know that an MD sir is also here. So my thesis was based on sentinel node in ovarian cancer, and it was the first ever study done all across India. And we had done this prospective analysis of 20 patients, a pilot study basically. And because at that point of time we did not have the ICG at our center, the open camera, so we had proceeded with the fluorescein dye. So I guess later the same fluorescein dye, sodium fluorescein that you've been using for breast cancer study. So that was the idea I got, and I used it for central node and ovarian cancer, and we got good results with that. So I shared that screen with you. So now during my study, I did come across certain situations where the ovarian mass, because we know that we're using it for stage 1 and 2 early ovarian cancer, right? So many times when you come across such masses which are deeply impacted, maybe certain cases which are post endometriosis or something like that, where injection, identifying the IC, it would have been difficult.
Yeah, I think that this is one of the problem of this technique, because you have not always the same situation. You have every time different situation. It's not like endometrial cervix cancer where you have the cervix, you injected the cervix, it's a standard procedure. In ovarian cancer, the situation is different. You have a situation with endometriosis, or you have a situation where the ovarian mass is attached to the uterus and is completely obliterated the utero-ovarian ligaments. So there are also situations where for oncological outcome, oncological aim, you have to do en bloc the hysterectomy. So there are all situations where it is not possible to do the perfect injection. We believe that it is a field that is we want to continue to study this technique. We don't know if it's possible and we reach the same results of the endometrial and cervical cancer. But we think that there are all problems that we are studying that we have to look forward.
As usual, nice presentation, very nice insight about the sentinel toxic and endometrial cancer. I have two questions, the basic questions. Number one, you see that 1977, initially the Cavalry is conceptualized this sentinel biopsy. It is established in renal cancer and melanoma and breast totally vaccine. But despite of even decade, despite of why the gynecology is struggling to establish the standard of the sentinel. What I believe in people staging in early cancer. So that is the main important thing. We have to put a staging to diagnose what stage the cancer is, like endometrial and ovarian cancer. Until unless you remove the node, so how to establish the node is involved or not? Because there is a false negative that is 5%. Apart from this, there will be the macrometastasis less than 2 millimeters. There will be the retrograde, also the state of the lymph node. And also, this thing that the difference, the way it's taken, that malignancy, endometrial and ovarian. So in these cases, like around 10 to 12% patients having there, suppose you are not doing the lymph node section, so you are putting some kind of injustice to the patient. I feel like that way. So how do you manage this kind of patient? And why you are facing the challenge to establish the sentinel node biopsy in gynecological cancer extent?
Yeah, this is the real central focus of the concept of the sentinel lymph nodes, because all study from, as your professor said, from other cancer, not gynecological cancer, for breast cancer, and after decades where we have performed the full pelvic lymphadenectomy, we were going to a new era, the era of less is more. So in this new era, the situation is changed, and all kind of tumors where this technique is feasible is starting to be applied. I think, but we have to talk for each tumor separately, because not all tumors are equal. All tumors are different. So, for example, for endometrial cancer, that is one of the most studied cancer for the sentinel lymph nodes, we say that the first studies are focused on this topic. So to find, the first question is, the sentinel lymph node reflect the status of lymphnodal, the lymphnodal status, or there are skip metastases, there are false negative that seems that there are node positive non-sentinel lymph nodes. And for endometrial cancer, we can show a lot of studies where he demonstrated that the rate of false negative is rare, it's very rare. The same for cervical cancer. For ovarian cancer is too early, because the data for ovarian cancer say are in contrast, because the two first trial with few patients say that the rate of false negative is very low. But our trial say that the sensibility is not so high, it's 70%. So for ovarian cancer, I think we have to improve the study. We have to study more. We have to do more study and improve data.
Hi, Stefano, it was a very nice presentation. I just want to know, even in our center, we have been doing sentinel for endometrial cancer. But very soon we'll be starting for cervical cancer also, because we just procured that definition. So in case there's a 2 centimeter mass in postmenopausal women with breast especially with the vagina, I think the injection has to be interesting, just injected in the place where there's no tumor. But what if both are involved? And where exactly should be injecting the
You think the right place where we have to inject if we have
there is no normal
yes.
cervix.
As I said, for endometrial cancer, it was done a consensus also for cervical cancer. I don't talk about this because I want to be quick, but there is a slide where when at this point,
Recognize cervical cancer.
And also, are you doing,
but there is a consensus, sorry, there is a consensus of also for cervical cancer. And this consensus say that you have to inject near to the tumor, but not in the fornix. You have to inject in the area of the mucosa free from the tumor, but not in the fornix. You have to, but if there is a situation where it's not possible to find any area of the mucosa of the cervix where you have to inject, maybe you can
into the tumor or?
here. This is the consensus for cervical cancer. And here there is the answer to your question, I think. You have to inject at the margin of unbordered mucosa, avoiding a vaginal formation.
And are you doing frozen section for the sentinel nodes?
In our institution,
Yeah.
you want the through or you want the I want to be honest because in our institution we don't perform the frozen section. The guideline says that the frozen section of the sentinel lymph node is mandatory. But we use a lot the PET scan. And we know that I know that there are a lot of studies that say that PET staging of lymph nodes is not so sensitivity. The sensitivity is not so high like the anatomopathological assessment. But we use the tumor board. We do the review of the imaging of the PET CT scan, the CT. The other imaging maybe of the CT scan, the MRI, and if there are no doubt on lymph node, we directly to do surgery with a sentinel lymph node or after the full pelvic lymphadenectomy and the radical hysterectomy. Only when we have doubt, yes, we do the frozen section.
Thank you.
Great presentation. So do you explore the paralytic region also if you don't find the sentinel lymph node in the
Sorry, I don't understand.
Did you explore the paralytic region also with the sentinel lymph node in high-risk cancers if you don't find it in the pelvic?
It depends from the pattern of drainage, because if you have clear the pathway, the classical pathway, we know that the uncommon pathway of drainage is around 4-10%. Okay, and there are some situations where you not find sentinel lymph node. You inject and you don't find sentinel lymph node. And in my opinion, there is not the same strategies for every of these cases. You have to see what is the problem, because if you say that there is a block of the drainage pathway, the problem is this. If you say the channel that follow an uncommon way is not across the uterine artery laterally at the uterine artery, but follow the mesoureter, remain medially, and go to the presacral part, common iliac part, lumbosacral. So in this case, you have to go with this section also in this part. But if the pathway don't reach this part, is not necessary. Unless if you have the doubt, the CT scan, MRI doubt, preoperative doubt on lymph node in this area, so you have to extend the dissection.
Thank you for an excellent presentation. I request the chairpersons of this session to remain seated. There are two people who have to leave, so we'll do a small felicitation right now. I request all the participants to please stay because we have two interesting sessions and we would love to hear what you practice in your institutes also. So first, may I request our guest of honor, Professor Major M.D. Ray sir and Shweta ma'am to felicitate our chief guest, Dr. Stefano. Please. Let's have a picture. Can we have a small May I request Dr. Stefano to please felicitate Ray sir because he is my mentor. And we have. May I request Dr. Stefano to felicitate Shweta ma'am, please. I request Dr. Stefano to be here and felicitate our chairperson, Dr. Rahul Modi. You have some time to stay. Thank you once again to all of you for making this possible. It means a lot to me, and I'm looking for more future collaborations. Thank you, Dr. Rahul Modi, for being here. Dr. Dweeb Jindal. Dr. Dweeb has his father-in-law admitted in hospital, but he still said that I will not miss it. So thank you, Dr. Dweeb, for coming here. Dr. Shruti Devi, who sincere regards because she has come all the way to attend and be a part of this CME. Thank you. Dr. Apurva Tak for making this possible and being with us here today. Dr. Apurva Tak. May I request Dr. Stefano to also felicitate the chairpersons for our earlier session, Dr. Sanjay Padeshra, please. Thank you, Dr. Sanjay, for coming from afar and being a part of this CME. Dr. Parminder Kaur.
Okay.
Dr. Nagi has had to leave. I request, now we'll be starting with the panel discussion. I know Dr. Ray, Dr. Shweta have to leave, but whoever is here, please join us for a small interactive session. Dr. Rahul, I hope you are here. For the panel discussion, now we'll be starting with the panel. We have our moderators who have put together two interesting cases. And may I invite, thank you, Dr. Stefano. May I invite Dr. Abhinav, consultant medical oncology at Manipal Hospital, DWARKA, who has diverse experience in multiple cancers and was awarded for his oral research paper at Jaipur, received the first prize in a quiz in the national level innovations in oncology, and also at MP Roycon, and the runner-up prize in the poster presentation. He's been invited for as a speaker at various national conferences. Welcome, Dr. Abhinav. Thank you. Uh, Dr. Abhinav is here, I think, to steal the show. Stay here. And we have our other moderator, Dr. Anandita, who is come from Ludhiana. She's MCH Gynae-Onco from Amrita at Kochi. She's a laparoscopic and robotic surgeon and deals with breast, ovarian, uterine, cervical, and vulvar malignancies. And she has numerous publications to her credit. Welcome, Dr. Anandita. Hi. Panel.
So I'm Dr. Abhinav Narvati. I'm a consultant medical oncologist here at MANIPAL Hospital, DWARKA. I'll be moderating a session on ovarian cancer. I would like to invite my panelist, Dr. Nilanjali, who is an associate professor in the Department of Ops and Gynae in Delhi. Dr. Vikas Thakur is head of the department and consultant radiation oncology at our own Manipal Hospital. Dr. Aki Agarwal, who is a senior consultant gynae and robotic surgery at Apollo Cancer Center, Nicholas Apollo Hospital, and Dr. Stefano Di Berarino, who is the gynae-oncologist at Jimli, Rome, Italy, and Dr. Anandita is there. So first I'll finish my case and by the time Dr. Anandita can join the panel also.
We have a photo. Let's have a photo of the panelists and the moderator also. Dr. Anandita, you can also join and then we'll start the discussions. Since Dr. Rahul, Shruti and Parminder are here for a small time, we want...
a little of us are left, so everybody is in the panel. So I'll start with the case. So the classical case, 62-year-old female presented with complaints of abdominal distension, abdominal pain, sense of fullness, subsequent to eating, increased urination frequency. So initially, suppose we start with a gynae-onc. I think, ma'am, both of yes. So, ma'am, what would be the first investigation you will be advising for a patient, 62-year-old female abdominal distension, sense of fullness, abdominal pain, increased urination frequency? So, start.
First would be an artery.
So, for the first visit she's coming to us, with these complaints, we have an ultrasound whole abdomen.
Generally, females present to a gynaecologist, not to a gynaecologist. So, presented with we underwent ultrasound abdomen. So, finding was an excel mass on pelvic examination and on pelvic ultrasound, there was presence of ascites in abdominal ultrasound. Suppose the female comes like this, do you write CO25 the first place, or you want to do an ultrasound, or you want to prove it, you would assume that it is going to be ovarian cancer, like C125 firstly or to be afterwards?
Oh, no, the first time. So if this age group, 2-year-old lady with Dexamab, so CA-105 will be definitely advised with the first one. I can choose to go for a point of care ultrasound, like you're asking, I can do it myself to characterize the mass more, but then CA-105 is mandate.
So Dr. Vikas Chaudhary, you also agree with this?
Yeah.
So,
Definitely, first we'll go with CA-125 and then followed by.
so this is a very normal case, and so we present, we will go with the abdominal ultrasound, routine test, CCFT, test, C125, right?
Ma'am, Paki ma'am, I would want to ask you, what is the tumor marker pattern that you follow? And do you follow RCOG guidelines, or do you have institutional practice to be doing a set of workup at the initial presentation itself?
So at the initial presentation, we do CA-125, we do CEA. The others we can hold off because she's post-menopausal, we are not really thinking, and we are thinking real ovarian at the first. So we can do it in a stage manner. Now supposing that is in those those are normal and there is nothing there, then we are thinking maybe Gynae-Oncology or something else, and then we order a second. So there is no institutional pattern per se. It depends on what's the patient's clinical history, what are we suspecting, because we do have to be judicious when we are advising investigations.
Basically, a lot depends on the history. You take history, what is she saying, and then you decide that what can it be. But yes, in a 62-year-old female with an nasal mass on ultrasound, you will definitely go ahead and set up an investigation. So then you consolidate your diagnosis.
And as an institutional practice, we also do CA-99 for
Yes.
this case.
So yes.
CA-105, CEA, and CA-19.
And you also follow the RMI scoring. I know you are at AIMS, you are here. Do you get reference from general gynacs after RMI?
Almost never. If I even when the patient is opened up, there is a laboratory, there is disseminated with the cancer in the body.
So Dr. Panu, what is your practice in,
I don't remember, just the patient did perform the CT scan.
No. So the first investigation we do an ultrasound.
Okay.
So
at first, we usually do a
you don't
ovarian cancer. We do
you don't do ultrasound there?
No.
No, you
Ultrasound, yes.
yes. First you do
ultrasound, yes.
Okay. So now my next question to all the three gynae-oncologists: what is the next step? After you have got an XL mass, you have CA-125. Now, what is the next step? Do you go with a PET scan first, or you do a CT abdomen and proceed with the surgery? That is a very important question from my point of view.
So, well, the NCCN says that we can either go for CECT chest, abdomen, pelvis, or we can go for a PET scan. And at our institution, we are going with CECT chest, abdomen, and pelvis. I'm assuming that we have now diagnosed her as COPD. So in that case, we go ahead and
we haven't diagnosed her as just
Part of the work.
part of the workup.
no. So you mean the CA-105 is raised definitely?
Yes. It is
Yeah.
all,
CA-105 raised and makes the mass polycystic or maybe showing characteristics of COE. And in that case, of course, we go ahead to the next step, that will be CECT chest, abdomen, pelvis.
okay.
Would you consider an MRI?
I was about to come.
MRI abdomen.
In this lady, CA-125, 200, we do see that in pelvic tuberculosis also, always lower down in the list. So in my mind, I would order an MRI pelvis, look at the ORAD scoring, because that tells us a lot of things. And of course, if you want to look at a chest disease, CT is good.
But in particular, this case with the symptoms, would you still consider she's likely to be CAOP? Would you know that even if you characterize the mass based on the MRI and you would need a CT scan after, so would you be choosing with both the modalities, or would you straight away jump to CT? What would it depend on the patient?
I think it would depend on the patient profile, also where you're sitting. So I have told we have the luxury of a guide MRI. And the patient is affording, I'm probably going with that first. But of course, if we say for the general population, it is the CT we should be doing, CT chest, abdomen, pelvis.
For the last,
So I beg to differ here, even if my patient is reporting and if she's a 2-year-old with such symptoms, headaches, the mass and CO2 of 200 something, you would say, I mean, 200 something, I will rather not waste time on even asking her for an MRI and go ahead. I'm assuming that she's COPD. I'm even going to operate her assuming that she's a COPD.
Okay.
So I'm going to object that.
So the patient has ascites.
Maybe we can ask the participant on what does he feel.
So yeah, I'll go to him also. So you do a, so all of you agree that you will do a CT abdomen, chest, or maybe a PET scan. Okay, and in such cases, again, you want to go ahead with the NACD approach or upfront surgery?
How would you evaluate, how would you evaluate operability at your center?
Yeah,
What
we
are
were
the criteria?
discussing a lot about, laparoscopy, laparoscopy. So now the question comes in a case like this, you're seeing ascites on ultrasound.
Because you use the PET scan or CT scan to understand if the patient is operable.
So do you decide operability on a scan or you're going to open and?
No, we do diagnostic laparoscopy.
You all three agree?
Yeah.
I agree with you, I agree, but that's not what we do. But yes.
So we are talking
I
about
think
your
that
day-to-day
comes
practice,
back.
doctor.
I would do an assessment lab. We did it, we saw some scorings earlier in the presentation, do an assessment lab, decide operability and take biopsies also. Yes, since we don't have.
Any rationale behind doing a laparoscopy and seeing a laparoscopy and seeing this? If
What are the complications that
so,
you encounter?
the benefit is going to be same. Even if you start with NACD and do a interval cytoreduction or upfront cytoreduction. So why do you want to do this? What is the rationale? So I want to know this from all the gynae-oncologists here. Why do you want to do a laparoscopy and see?
Yeah, we always do a laparoscopy because the CT scan have I do an example. Okay. But for example, for lance trial, where the CT scan is a tool to the CA-125 and CT scan are screening to patient for lance trial for the EDS, minimal invasive EDS, interval debulking surgery. But I said that in the majority situation where the CT scan says that there are no disease in the upper abdomen, there is always disease. Always.
So,
Yes.
yeah, so many a times,
You can take the
on imaging, we don't know. On imaging, there will be nothing in momentum, but when we do a echo, definitely many a times we find it out.
And again, peritoneal disease, very
Yeah.
difficult to pick up.
That's the reason we,
when there is no disease in the PET scan or a
Yeah,
CT
yeah.
scan, then you
So
can open
operable,
and see,
yes.
yes. But if there is ascites, visible ascites, still you want to go ahead with, surgery first, you drain, you want to drain it.
If the patient,
Suppose you drain it and there are positive
if the
malignancies.
patient was inoperable,
Yes.
if the patient is operable, you need the histology. So the laparoscopy is not only to see if the patient is operable, but also to see the malady at the beginning. Because a disease with a Fagotti score of 12 and a disease of Fagotti score 6 is a different disease. And if you see how is the disease at the beginning and how respond chemotherapy is an important information.
You want to,
to see how the disease go on.
very good. So any other difference of opinion, Dr. Anand?
I think practice varies from institute to institute. When I was in Amritsar, what our protocol was, first we used to do CT scan, X-ray chest, CT scan. If X-ray is suspicious, only then CT chest. So CT abdomen and pelvis, if we think that on CT abdomen and pelvis it is operable, then we used to go straight forward with laparotomy. And if on CT we used to think it can be operable or inoperable, then we used to put a scope and see. And what I personally feel is that CA ovary, you cannot decide this is stage or this is operable. Even ovary is operable in stage 4A and 4B. Even we have operated 4B, purely inguinal node was positive, the rest everything was operable. So in ovary, you cannot take a stage and decide. You have to see the performance status of the patient, age, and all other things.
I think Dr. Paki, you must be doing PET scan because in Apollo, I know PET scan So,
But again,
academics
for
should get
peritoneal disease, again, the sensitivity for peritoneal disease is poor. So when we are really, there was a lady who had this diffuse peritoneal carcinomatosis. Now PET didn't pick that up. When we did an assessment, her whole peritoneum was studied. So that immediately changes what you are going to plan for her. So you would go into even in the presence of ascites.
There is kind of guidelines to a laparoscopic assessment and
Yeah.
an institute might choose that.
So the patient underwent primary debulking surgery. Optimal debulking could not be achieved due to pattern violent involvement. So I think I'm the only medical oncologist here, but still I would like to ask this question. Which agent would you prefer to combine with platinum? Agent in frontline treatment of it, although this is question to be taken by myself, but still.
You can answer it if you want.
No, even I can answer this one. Backlink are more infectious.
So yes, so there are a lot of trials and every trial has.
And you give family weekly.
That's what I'm doing. So here our gynae-oncologist is, so yes, you take this question. Which agent would you prefer to combine with platinum agent in the front line? No, along with platinum. Platinum is there.
So maybe that nicely, maybe.
I think the dose dense regimen.
Suppose it's PS1.
If I
Definitely, Paclitaxel 3 weekly is the choice.
So yes.
The only time you would give weekly, I think, is when you expect more side effects and you want to kind of make it a dose dense.
So there have been trials that have shown, we follow that protocol that, the patient has a PS of 2 and you want to go ahead with a weekly combination, but the study MITO-7 was used, that used weekly paclitaxel in a more patients who have a good PS.
Yeah.
So weekly paclitaxel has some sort of angiogenic effect. And that's why we prefer to use weekly paclitaxel when the disease is disseminated, there are high risk. So contrary to what we think that 3 weekly should be used in a good PS patient and weekly should be used in a PS2 or PS2 patient. So this is different. This is just opposite. When you have a patient who has a good PS and you want good responses, you use the MITO-7 protocol, that is 80 mg per meter square of paclitaxel weekly. So it has given better results. I think there was also a Japanese study which has given an overall survival benefit also when using paclitaxel weekly in combination with platinum. So any other choice rather than paclitaxel? No. Okay. So this is one question again for me, but we will discuss it with Dr. Paki and Dr. Stefano. What are the cases where you would ask your medical onco colleague that please add the bevacizumab to it?
Where we have added
Dr. This question is for you as well because you are going to come to me only.
Where we have added is situation C, where there was stage 3 and 4 disease with ascites. That's
so anyone.
probably the only time we have added. Yeah.
So frontline bevacizumab, there is no data. There is few phase 2 trials which have addressed frontline bevacizumab in the new adjuvant setting. But in the adjuvant setting, where you're going to use bevacizumab is these are the high risk features. So high risk of progression was defined as stage 4 disease. There you can use where using bevacizumab has turned into overall survival benefit. Stage 4 disease, inoperable stage 3 disease, or where suboptimally feeble, that is more than 1 centimeter in stage 3. So these are few criteria where you want to use where it has translated into overall survival benefit. None of the data suggests that you should start bevacizumab upfront in a neoadjuvant setting. You should always start after debulking. So here we can see in the iconic trial GOG-218, when there was OS benefit in patients with ascites who have been started with bevacizumab. This is also pattern and also progression-free survival, icon 7 trial, bevacizumab plus minus standard therapy. So I have, few scenarios. A patient presenting with ovarian cancer with extensive intra-abdominal disease, stage 3C, receives conventional fatty carbo, bevacizumab, with good response and proceed to surgery with R0 resection, leaving regulatory and reimbursement issues. Would you most likely recommend this maintenance therapy if genetic? So now I will reveal there are two cases, and depending on the what genetic mutation report has come. First of all, one question to everyone, all of you. So even patient with ovarian cancer comes to Dr. Vikas also. So when do you advise BRCA or HRDs? Upfront, or you leave it to the medical oncologist? Being the question to Gynae-Oncs, because they are the ones who are doing the initial assessment.
We do the BRCA and the HPV, the first biopsy.
First biopsy. Dr.
Logically, yes.
Ideally,
So you're offering HRD and BRCA to all of your ovarian cancer patients.
Ideally, yes, we are, but we are not doing it completely because of cost constraints. It's not developable. Your cost, so yeah.
So which are the cases where you definitely do it?
Yeah, so young onset cancers,
So
family history of cancers, all those, and then history of breast cancer in the patient itself, or history of breast cancer in the family. These are some of the, and
high risk.
failed breast cancer, all those, yeah. Specific.
Dr. Bharti.
Yeah, I mean, if it's possible, we do it on the first, when we did a biopsy and we were assessing for
Any
NSC.
particular subset where can leave testing?
If it's a, but
Oh,
all
this
high grade
is
should,
the
all high grade
first-
serious ovarian should have BRCA.
What is the genetic
We're
test?
looking on at advanced stage, early stage.
Yeah. So we are not talking about stage. Whenever we talk with a medical oncologist, we're not talking about the stage we can do. Our work starts from stage 3, 4.
My
So
question is, what are the tests that you are doing at your center, in cases which mandate, in your opinion, this one has to undergo genetic testing? What is it that you order for?
HRD in the,
HRD in the initial, or do you go for MLPA and BRCA testing?
So I'll come to that. So suppose you guys have read this scenario, another scenario. In this, the patient underwent and then surgery and with the R0 resection. Second scenario, the patient undergoes R0 resection and then receives cyclophosphamide with paclitaxel carbo with good response. So now I'll ask all of you, what would you most likely recommend as maintenance therapy? So
You made MCQs.
No, but
not this is
what is the result?
no. So these are the results. First scenario,
Scenario.
yeah. So basically, this is all for the medical oncologist. But yes, I will. So germline BRCA mutation. First of all, how do you go? You offer germline or somatic testing?
Both.
Both. No, in particular order.
At first the somatic, and after the germ.
I don't think it should go the other way around.
It's germline
It
first.
should be germline first,
Somatic
and then
and
somatic.
But you have the diagnosis of ovarian cancer in operatory room.
You come again.
You have the diagnosis of ovarian cancer in operative room during the first surgery.
Okay,
So we do
so
the somatic BRCA mutation
you
and
you
the
can
biopsy.
send the blood in the OPDs.
yeah, no, but correct me if I'm wrong, that isn't NCCN saying that we do HRD first and somatic
It's
testing
actually
first and.
germline, then somatic, then HRD.
Okay.
That's the way. You should go first germline, then.
What do we want to do the germline test?
So
The germline test, what is in your opinion, the best moment to do the germline test?
at the when the patient has been diagnosed, at the very first.
And when you have the diagnosis with the examiner histological examination.
No. So for somatic, you need a histopath report. For somatic, you need a biopsy block. For germline, you don't need.
No, you don't need it.
Yeah.
Of course.
So you do the germline.
You perform the germline test when you have the diagnosis.
Yes.
And we do the diagnosis with the biopsy.
The biopsy.
And with the biopsy of the diagnosis, we perform the
So
split.
still, even if you have the block, the reports will come. But ideally, you should send the blood first for the germline. But what you are doing is you're sending both the germline as well as the biopsy.
Yeah.
So you're testing both at a time.
We do the germline of the blood.
Yes.
Okay.
So you're doing it simultaneously. You're not doing, you're not doing first germline then somatic. You're going ahead with both of them. So that is also a fair option. But doing a somatic first and then germline.
Question is, how will you get the somatic samples?
By the biopsy, by the
If you have already done it, so you are sending the germline in the OPD itself in the first visit.
yes.
Then you are operating. You have the somatic testing.
So many of the cases will come with a biopsy report. That time you need to send germline first,
Yes,
and then
so
you
that's
can,
a different scenario.
yes. What he's trying to say that when I'm operating, I have tissue, then I will send it for the somatic and the germline.
Usually you see patients that come to you when a diagnosis can.
Yes.
Usually I see patients
Without the diet. Yeah, I got your point. I got it. So genetic result testing in first case, if germline or somatic BRCA mutation is there, what you are going to give? If there is germline palbate mutation is there, if there is BRCA wild type but HR deficient with LOH high, BRCA wild type, HR proficient with LOH low. So this is quite complex. This is for us. But still, what sort of maintenance therapy, Dr. Spano, Dr. Baki, Dr. Angela, Dr. Lansley, what we offer for maintenance
For
therapy?
BRCA, what's all of that? Or olaparib with bevacizumab also can be added depending on the disease.
I think the lady who had Bev earlier should have
Should
Bev
have
maintenance
both,
plus
yes.
olaparib.
So
The other one
generally,
can
patients
have
who have taken the bevacizumab, we offer them Bev plus Bola maintenance coming to the Powler trial, and patients who haven't in which you haven't used bevacizumab, you can go ahead with Bola Rucaparib, and Niraparib anything. But what is your preferred choice? All five of you?
Olaparib is large too.
Spano, Dr. Paki,
also for BRCA mutation.
Olaparib.
And now BRCA negative, HRD positive then?
There's also one scenario.
Yeah, just a minute. How you choose between Ola and Ruka when
So, according to in India, firstly olaparib was quite costly, generic of Rucaparib. So we used to write Rucaparib. So I think we have stronger data for olaparib. So that's why now olaparib has come. Now we are starting to use olaparib.
But come on, previous discussion where it was germline, so take which first and everything. So I think if you took the SGO, they actually follow what he's saying, that somatic was followed by germline. Because I think in India, we follow the opposite, it's because of the cost.
Cost.
So ideally, if you don't have cost restraints, ideally it's to send both.
Both.
Or second ideal method is to send somatic was followed by germline, but then because our scenario is that way, that if you do only germline, it is 12,000 rupees, and if you do a full panel, it's around 70,000, even after applying tools from a medical oncologist. So that's why this thing has set up.
So why do we send germline more? Because germline is going to cover 25% yes.
25%.
And somatic is only around 30, 40
more. But if somatic is negative,
then
you have
can
germline.
yes, that is one.
So the Western counterparts actually follow somatic first policy because they
Because
don't have a problem with the cost.
Finances, yes. The Western world follows that they send both. As Dr. Spano said, they send somatic as well as germline. But in our scenario,
But as a medical oncologist, what do we give for germline palbate?
so olaparib or Rucaparib. It's a
Hello? Because see, if I look at the solo data, it only says about BRCA mutation.
yes.
It doesn't say about palbate.
So now
Palbate to the part of HRR.
HRR, yes.
It's not BRCA. So whether you will follow the Paula or whether you will follow the solo, what you will follow is salary.
PALB2 mutation, I can follow both, but preferably I will follow Paula because in Paula I'll show you 50% of the population was HRD.
Yeah.
HRD deficient. So
we don't have data for HRR as of now.
yes. So in general, what is the optimal approach to mutation testing for? So we have already discussed this. So again, I think we have already discussed this. So yes, this is all about PARP inhibitor and homologous recombination. I won't go into detail because we have another panel waiting, but this is what we are talking about. So approximately 50% of high-grade serous ovarian cancer alteration in the HR repair genes. You can see on the right side, BRCA1, BRCA1 germline, BRCA1 somatic, BRCA2 germline, BRCA CDK1, 2, RAD51C active gene, GORAT. So this is, around 50% you're going to get something in the HR repair gene, some sort of mutation. And this is the list of, from 1960 to 2020, this is how PARP inhibitors have come, and 50 years on from the first PARP discovery. So FDA approved PARP inhibitors. So now niraparib is approved irrespective of HRD or BRCA testing. You can still, there was a benefit in the Athena mono trial that you can use niraparib irrespective of HRD or BRCA testing. So,
Primer also use niraparib?
Yes, primer also.
And OS advantage is there?
Yes.
But it's not available in India.
Yeah, niraparib is not available.
Niraparib is not available.
In India.
No.
In India, it's Rook and Ola.
Fine.
Maybe.
We haven't designed
biosimilar. We are waiting.
Science are taking up all the stock.
Eva is not the European product and Ola is an American product.
So,
So the initial signing was with an American.
In Italy, you have niraparib available, right?
Yeah. Europeans use niraparib more than.
So, Spano, do you use niraparib more than olaparib, or there also olaparib is the first?
In the HRD positive.
Yeah, in HRD positive.
First niraparib.
You first use HRD?
Niraparib. Because it's designed in Europe.
Okay. So this is the Paula 1 trial design. Olaparib 300 BD with bevacizumab versus placebo. So then you can see, I think, you can see here in the BRCA mutation, it is a median PFS is 37.2 versus 21.7, and in the BRCA wild type, it is 18.9 versus 16. So again, this comes 60, around 50% of patients were HRD positive. This is the PFS Kaplan-Meier curve. You can see HRD positive using BRCA. You can see the curve separating, but in the HRD negative or unknown group, you can't use, there is no benefit of adding Ola as well. So thank you. I'll ask Dr. Nandita to come and
We
share
have
the
one case.
second case.
For that, something good. To be confident.
And we use
No, that was okay. 2.5. Hi.
Okay. So this was a case, a 71-year-old female. She had a history of vaginal hysterectomy in view of uterine collapse 1 year back, but she has not shown us any OT record or histopathological reports. Then she presented with the pain lower abdomen on and off since 1 month, and she underwent ultrasound at the local center, reporting a 5 to 3 centimeter complex right adnexal mass. So basically on examination, only their base mass was felt
on per vaginal examination, rest everything was normal. So, what will be our next line of investigation and how should we proceed?
So there's an next mass on ultrasound or exam?
On examination as well as an ultrasound, a patient is already come with an ultrasound. She's a post-vaginal patient, 1 year back.
And age?
71.
17. So tumor markers would be the next step. I'm assuming that some children already based on the addiction mass. So
Yes.
tumor markers would be the next step.
So, next tumor markers, we did all tumor markers in CA125 CEA were normal. Then next, I think.
Here, excuse me, here, CA 19.9 also you do or
No.
only these two markers?
So we do see a 19.9.
Yes, three markers.
Three markers. That's
Yeah.
Right, okay, in our institute of practice, we only do CA125 CEA. We have never seen CA 19.9.
right. So this is rare, but yes, that is also so.
So next, then
Let me go for a higher
higher imaging. So as patient, we have done with CT chest, MRI abdomen, and CT abdomen. Can
There's a lag of 1 second. So you just wait once you click.
can we start the video?
You want to go back?
No, this video.
That's the script.
It's a. Sorry. There was in this MRI image, there was showing this at one point small bowel infiltration as well. So basically on MRI, it was 8 to 10 centimeters with very small bowel infiltration. So Dr. Bakshi, how should we proceed further?
Now we have to counsel her about this mass needs to come out. That's one. So we need to prep her for a laparotomy. So now again, bowel preparation, something very individual. In this case, looking at what we have written here, I think it makes sense to prepare the bowel and work her up for a laparotomy, all the preoperative fitness and everything. So in our mind, obviously ovarian would be the first thing because in a vaginal hysterectomy, normally the ovaries are not. So we are thinking ovarian, but of course we have to be prepared for everything else.
You've done a metastatic workup for her. You would do at this point or
We did a CT, we did a CT, we did, right?
CT chest.
Yeah, we did all.
So yes, we have counseled the patient. As Madam has said, we have prepared the patient.
I just have one question. So what does the house think? If her CA is normal with a bowel involvement, would you like to go for a sigmoidoscopy for her before proceeding to surgery or not necessarily? Would you?
Depends from the market. If you have CA or CA 19.9 positive, maybe coloscopy sigmoidoscopy.
CEA would suggest transmural infiltration.
Here was normal.
And depending on her status, whether she's a smoker or not, that is also because CEA may be
Yeah.
falsely positive in that scenario also. So CEA can give you a clue.
If you just give the hint, you are not.
But if the
Yeah,
CA would then do a.
Yeah, my question was that if CA is normal,
Yes,
then would you like to do a sigmoidoscopy?
Not in all cases. I beg to differ.
And that's why I asked this question because there can't be a consensus on this because some might prefer to do it still and some might not prefer to do it still, but then.
Are we going ahead with the surgery?
Everyone, I think, will agree. We go for the surgery and what
What hysterectomy at nexal mass, we have to know what's going on.
and what would at this particular point your surgery entail? What would you counsel the patient?
So in my mind, I would probably start off thinking it as ovarian.
Okay.
And counsel her for removal of that mass, whatever metastatic disease.
Frozen first.
Of course, frozen of that to know the diagnosis. And then, I mean, if we were thinking ovarian, I would also be thinking of removing the omentum as a staging thing, all of that. But yes,
And how many times have you seen frozen telling you that it is negative for malignancy? If the frozen tells you, but looking at the MRI, solid cystic ORAD spore lesion, you look because you are going to deliver it intact in the capsule. You send it for frozen. They say it is negative. But as a surgeon, you have your reservations about it. There is no intra-abdominal spread. Now, what exactly, what are the components that you will be excising in this surgery? Would you do extra? Would you do just this much and then prepare her or the relatives for the repeat surgery? How is it going to?
It will entirely depend upon the cut section of the tumor. I would rather say that with the cut section, if it is very clear that it is malignant, we can go for it.
So AIMS has practice of cutting open.
But
Yeah.
we cut open the specimen, they have a mini stroke.
Exactly.
Then you have cut open
So
the.
the institutional practice varies.
Very.
In government institutions, the postgraduates are trained to cut and see. In private, that is not the case. The pathologist wants the entire intact capsule. Otherwise, they are going to report it.
As capsule rupture, as one sees.
So that's my question. What would you do now? And what would you do?
In public hospitals, you have to send the intact.
No, in the private hospital.
In the private.
I can't understand why.
So I don't understand.
I cannot understand why. I cannot understand.
Well, even I can't understand.
We should have pathologists from the panel.
That should be cut. That should be once it will take up.
Surgeon.
Yes, that should be cut by the pathologist and then.
They want to do their own
proceed
costing
for that.
actually. They want.
Then we have to proceed for that.
Yes, it is very, I think it is very important for the surgeon to know.
Yes.
Because you can
Yes.
feel it.
Then only the surgeon will decide the further steps.
Exactly.
It is not-
Suppose you cut open, you can see what the MRI shows. You are suspecting, your pathologist saying in these sections examined, it is negative. What now?
I think we should still do a generous bit of the momentum for staging.
Okay, infracolicomectomy.
Yes, in front.
Next,
We won't even wait for the histopathology
Not so
for.
much.
we just, okay, infracolicomectomy next. What about the node?
Nodes not so much because if they're not enlarged.
Would you open the retroperitoneum and assess?
You can palpate them without opening the retroperitoneum.
So you're saying that
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 is
is
stage, huh?
you're asking, we have cut the specimen already and then we are
We have this, we think it is suspicious.
suspicious of malignancy.
We think it's suspicious. Your pathologist is saying it is negative for malignancy right now.
Right. So when we do a cut section, sometimes we're like 100% sure that no, this is malignant. In those cases, we will go ahead with a lymphadenectomy.
Okay,
And
suppose you are also dicing.
I-
That's the situation.
then we rely on the pathologist.
So she said it's negative. So what at this particular point, she said she's going to do palpate the nodes from without opening the retroperitoneum. What would you do, Stephanie?
If I have a frozen section, it says all is negative.
I think I asked the wrong question. Your frozen confidence rate is how much? 95, 97%. In Germany. How is your frozen section?
But it's absolutely absurd because today I published one study of this frozen section to tailor the surgical decision today.
Okay.
Today is fresh today.
Wow, congratulations.
You are doing it now, today.
He published today.
Today.
Today you published.
Concordance was.
The problem of frozen section is not the underestimation, but the overestimation. If you have a negative frozen section, it's negative. If you have a positive frozen section, maybe it's negative.
It's, yeah. No, is it possible that you have a positive frozen section and it is negative later?
No, sorry, the opposite. So
Yeah, the opposite.
if it's negative, it's negative. The problem of frozen section is not the overestimation, but is the underestimation. Is the overestimation, not the underestimation.
It is the overestimation of
Yes.
frozen.
So for
A
us,
lot of frozen section that say borderline tumors at the final diagnosis is negative. Okay. No,
Is that
sorry,
so?
sorry. When you have a diagnosis of
Borderline.
borderline tumors, at the final diagnosis, you have usually, it's possible, you have enough of possibility, 50% of cases that there is an upgrade of the diagnosis,
Upgrade, no.
upstage.
So
Yes.
frozen upgrade,
Because the
never
technology is
upgrades.
For to say, you have to do radical things 2 times. Okay.
Coming back to my
Back to the
question.
question. What
My question.
I want to know.
Yes. So
With frozen section negative.
Yes.
No.
nothing. Just looks. Ma'am, would you do something?
so if nothing and I'm dicey, then not do. Very sure on first section, no, this is malignant.
But what kind of negative?
Negative for malignancy.
Mucinous, serous.
We do not, our pathologist doesn't tell us.
Because there is a cystadenoma, serous
I know.
cystadenoma is maybe it's totally negative. If you have a mucinous cystadenoma,
Yes.
it's possible to be a borderline tumor. So with a mucinous benign lesion, I do biopsy.
You do peritoneal.
But again, no lymphadenectomy there as well.
No.
Obviously.
So
Even if
almost
it
is
is-
is
That
for-
closing section tells histology also. Did that happen in Canada also?
Yeah,
They tell.
even at AIMS, you have been there,
Yeah.
and they are not very certain that this is going to happen. They do,
But not everywhere.
Looks like mucinous, they say.
Yes.
It
They
looks.
give you an indication. At Apollo,
I
okay,
don't
my side,
see what that says like that.
coming back,
So the operative finding was a highly friable vascular mass coming out like the hand only was just breaking down. And it was basically rising from the wall and both the nexa were embedded encased in the mass, and a small bowel was going through that mass, and there was the infiltration. So we have done a complete staging removal of the mass along with the small bowel dissection and stenosis, total lumpectomy, pelvic peritoneal lymph sampling as well.
so we have done a RA for her.
Yes.
So your point of saying that should we do a sigmoidoscopy?
But it was very,
But this is
It's all bowel.
But this
small
is-
bowel.
Yeah, and it won't change the management still, even if it is raising, then it's the same thing we are going to do.
So your sigmoidoscopy, colonoscopy would not have made a difference.
Yes.
Because tumor markers negative, breast assessment is also important.
Next.
So, I would like to ask all the surgeons. So, whatever your diagnosis based on intraoperative finding, you see over 25 not raised, specifically an ovarian with a bowel infiltration. UTP over 25 is written, otherwise also the kind of mass it was very friable, it was not a
Vascular
big
and
mass.
friable.
Yeah, there was no control of the mass.
Yeah.
So-
We're getting towards some sarcoma.
So it is.
So,
Already operated.
So, so basically it was high-grade dedifferentiated carcinoma, and on IHC, it was CT7, CT10 positive, MLD positive, cyclin positive, BCOR positive, P53 not mutated, Caldas1, Desmin, and SMA non-immunoreactive. So it was high-grade endometrial stromal sarcoma. But
Hey, wait.
Very.
Wait.
But, Francine, it's.
This situation, the frozen section lost all the function. Because the frozen section of sarcomas,
so we were lucky because we do not have frozen section facility that time in our hospital.
So the patient should be.
Next.
We call it
Frozen section.
So in that case, even if we have done just mass resection, we had already had a hysterectomy, and this was a complete surgery.
use,
Yeah,
even without the nodes,
Without the nodes.
Because
Notes, but we have not assessed.
the use
we have a
frozen
we said we
section.
have, but for a stromal sarcoma, no, had it.
Not the violin.
You said we'll not assess the
In
notes.
about
We assess the
the-
nodes, palpate and assess.
Palpate. We don't have a histopathological diagnosis.
the unit.
So my question is, up to it's a sarcoma. So nodes
Not necessarily.
necessary. Even if you have completely dissected the tumor, it is okay.
Final stage of
Yeah.
the diagnosis. The small bowel is infiltrated by the stroma.
if small bowel was getting we will.
So it's the first stage.
Stage. Mucosa was in that transplant.
Mucosa was?
In that, but muscularis of that small.
So it's not mucosa free, it's not.
Sorry, it's 3C.
Stage, stable stage.
3 or 4A?
What was it? Three.
Only until the mucosa.
No, what is the stage? Final?
We have signed the stage 3.
Only the serous of the bowel is 3.
Stage three. Next. Medical oncologist, he can answer.
So further management for.
Post-operative PET CT before.
Post-operative PET CT also was negative, there was no
What's the
FCC.
question?
How we,
will manage after surgery. She's R0, PET-CT negative.
So
Stage 3.
Stage
I'll
3.
go ahead with the adjuvant chemotherapy 6 cycles.
Which chemotherapy you are
Paclitaxel. So there was a
Here is
trial.
sarcoma.
Yes, so there was a trial in endometrial stromal sarcoma where paclitaxel was non-inferior to that ifosfamide and paclitaxel. So now medical oncologists have started using paclitaxel for endometrial stromal sarcoma also.
Do you
And what
use?
about gemdosi? No.
Gemdosi is never in the first.
Do you see the receptors
But
of
we-
estrogen and progesterone?
Yes, that you can see on the IRC if it is ERPR.
And do you manage the therapeutic option with the receptors?
So if it is,
Expression of receptors?
so if ERPR is positive, sometimes you put them on maintenance hormone therapy. Not very regularly, but 6 cycles of adjuvant chemotherapy paclitaxel.
But this is a case very because I honestly, I don't know if for stromal sarcoma of the ovary is different. They discuss from
So-
the stromal sarcoma of the uterus. In my, I honestly, I don't know so very well the pathology of stromal sarcoma.
Because the guidelines have recently changed and all the molecular markers of sarcoma, all the genetic mutated sarcomas that is into play rather than the point of origin. Am I correct? The B-form mutated. So it is very extensive and
Now,
I would want Dr.
yes.
Vikas
So,
to give his
I just
opinion.
want to know when you will send this patient to me, or you will not send one. Or you will go with some sandwich kind of thing.
We want to know from you, what is the right management?
I don't think I will say.
No.
He doesn't want to send.
See, sarcoma high grade, definitely that chemo part won't play that big role. So radiation,
Obviously, for the local recurrence prevention, we have to do. Will you do a EBRT only or a vaginal brachy only?
will do both.
Both. For the
Yes.
pelvic recurrence
Yes.
and the vault recurrence.
All
both.
recurrence. We have to do
You
both
will
of them.
not want.
And we have to discuss with me before start of the first chemo, whether
No,
how
this
to.
was ovarian or
Ovarian.
Sarcoma, we call it.
I think the origin is
It's
important.
not uterine, origin is uterine.
No, technically, what all?
Because we see extra uterine.
Then
Okay.
the uterus. So in my
Ovarian,
opinion,
no.
radiotherapy in this situation is not indicated.
No,
What do you
this
think?
is ovarian
I was.
stromal
If it is
sarcoma and
ovarian, then it's
Ovarian,
not.
ovarian, no.
Ovarian origin.
Actually, for endometrial stromal sarcoma to be classified as extra uterine, we need to rule out the uterine involvement. We need a uterine specific. In this patient already gynecectomy was done, with no issues
It's
of
a
searching
ovarian
for.
origin.
So-
that's why that's why I said I wanted
That's
to.
what
I was
here
thinking
before
over the-
about-
Otherwise, for an endometrial stromal sarcoma, you definitely said.
Yes,
This is ovarian.
ovarian, no.
Yeah.
And this is one of the rarest cases you have.
Yeah, it's rarest of rare.
We counted this case.
This is one of the rarest cases you have, I haven't seen an endometrial stromal sarcoma of ovary.
I think it's the first case.
Yeah, actually, rare cases we should not. Discuss like that.
No, that's okay.
No, but it is, if
Rare.
it is uterine, let's discuss if it is uterine, then chemo first, radiation first, or
Maybe-
sandwich.
So
Maybe we
sandwich
can
is
go
the
ahead,
best, best
yeah.
approach. Yes,
like the
sandwich is the
endometrial
best
approach, with 3
Yeah.
cycles paclitaxel, then radiation, and then complete.
That's
Okay, this patient is now getting the carboplatin and methylaxine chemotherapy and this is given by radiation oncologist. So basically, when I find out the literature, they say the ovarian endometrial stromal sarcoma background of endometriosis has been associated. And yes, some literature also says that there is a role of high rec in the ovarian endometrial stromal sarcoma.
okay.
There is
Thank
study
you.
that use IPEC for cancer.
Yes, yes, even Professor Day also does it. Yes, sir. So I would request Dr. Stefano to felicitate our moderator and
Also with
With the mouse, right? But because you were presenting data of bilaterality.
bilateral. The both ligaments, the pelvic ligaments
Oh,
and the
that,
uterovarian
oh, okay, of the same side.
of the same.
We'll start, Dr. Stefano, you will have to listen. First, we'll start with Dr. Pakhi Agarwal. Thank you, Dr. Pakhi, for making it possible. You can have a picture. Thank you. Dr. Vikas Chaudhary for being with us. Can someone call Dr. Vikas also for the presentation? Dr. Abhinav Navatia. Thank you for conducting an excellent panel. Dr. Anandita, thank you for joining us. And Dr. Vinanshi.
डॉक्टर अनादि वाला दे देना कुछ नाम है उसके डॉक्टर नाम ये तुम ही रख लो कल दे देना ठीक है दे दो नाइस कहानी तो जवान That? Where's name? You are in India for how many days? No, for how many days? The last days.
It's the early morning.
Okay. 2 days only.
Next time we'll come. 2 days before. Next time we'll come.
Don't contact her, contact me. Okay.
I will share the link on Google Drive.
And I see just 2 years ago in Japan when
She knows that.
brilliant. Very
I think this was the big one. Come very nice, very made my job very easy. I was just 13 April, half the day, then usually there is sufficient only organizing this Onco update CM. 13 April, 3 afternoon, Saturday, and then we
मुझे बता देना because मेरे Onco कल से नहीं डॉक्टर सरिता श्याम सुंदर and डॉक्टर अर्चना मिश्रा देखो ये पता मुझे बस बोला है एक जना ठीक है बाय बाय बाय
सरकार तेरे